Hello everyone, this is Larry from Classroom Guys, and today we will be exploring the approach to reduce consciousness during an on-call. Loss of consciousness is one of the common presentations that you may attend to during an on-call in the ward. Do you know what to do and how to approach it? While this video will not guide you to treat each specific disease, we will be providing you a general approach for this symptom. The Glasgow Coma Scale was described in 1974 by Graham Teasdale and Brian Jeanette as a way to communicate about the level of consciousness in response to defined stimuli. Despite being initially created for patients with head injury, you will find that GCS is commonly used on other patients as well. This scale was used to assess coma and impaired consciousness and consisted of three components, which are eye-opening, verbal response, and best motor response. It's the middle of the night and the ward staff informs you that a patient has become unresponsive. You need to know what you're dealing with. Is it a life-threatening condition like asystole? Could it be a stroke? A seizure? How quickly should you go and attend the patient, especially since it's a busy on-call? If you're still on the phone, ask for a capillary blood sugar stat if it's not already done. Like any emergency in the ward, the priorities are to stabilize the patient, identify the cause, and treat the cause. Loss of consciousness is a medical emergency with a wide range of causes. Hence, the patient should be attended stat. Upon reaching the patient's bedside, immediately assess the airway breathing and circulation. Check the patient's GCS and vital signs. Look hard for signs of hemodynamic instability. Don't forget the glucose level. Warning signs of unstable patients include altered mental status, shortness of breath, desaturation, tachycardia, and hypotension. Should these occur, start cardiopulmonary resuscitation following the ACLS protocol. Call for help, get a senior doctor on board. Inform your medical officer on call to participate in resuscitating the patient. Intubate if required. Setting intravenous large bore brannulas and drawing blood investigations. While resuscitation is ongoing, identify the cause of the drop of GCS. The causes of reduced GCS can be divided generally into central and toxic or metabolic causes. Central causes usually have neurological signs, whereas toxic or metabolic causes usually don't. Under central causes, you can divide it into febrile and afebrile conditions. Febrile conditions are, for example, meningitis, cerebral abscess, encephalitis, and cerebral malaria. Afebrile conditions consist of intracranial hemorrhage, subarachnoid bleed, brainstem stroke, cerebellar stroke, cerebral tumor, cerebral edema, or seizures. As for the toxic and metabolic causes, you can divide them into febrile and afebrile conditions as well. Febrile conditions are such as septicemia, UTI in the elderly, or thyroid crisis. Afebrile conditions consist of metabolic causes, organ failure, poisons, or psychiatric issues. The metabolic causes of reduced consciousness include hypoglycemia, hyperglycemia, hypercarbia, diabetic coma, hypothermia, dehydration, and electrolyte or acid-base abnormalities. Poisons or toxins that cause reduced GCS include wernicke's encephalopathy, alcohol intoxication, carbon monoxide intoxication, or drugs and medications like opioids, benzodiazepines, barbiturates, and tricyclic acids. Organ failure can also cause low GCS. For example, in renal failure, there is uremia. In hepatic failure, ammonia levels are high. Respiratory failure may lead to carbon dioxide retention or hypoxia, while cardiac failure may lead to poor perfusion, leading to high lactate, increased carbon dioxide, and hypoxia. If all the organic causes have been ruled out, it is time to consider psychiatric causes, such as dementia or psychogenic stupor. On a special note, acute delirium in the elderly may be caused by pain, acute urinary retention, constipation, medications, dehydration, infection, and electrolyte abnormalities. It is also important to obtain history whenever possible from relatives or reliable attenders who witnessed the symptom. Pay particular attention to the onset and also associated symptoms. Drug intake history, like what medications were taken or any sedatives that were given, any illicit drugs, and alcohol intake, are all relevant information. After obtaining targeted history, consider the differential diagnosis, perform a focused physical exam, and come out with a provisional diagnosis and commence with treatment. During a focused examination, look carefully for the signs of all the possible causes of low GCS. With a target history and focused physical exam, we can then begin to order specific tests or imaging to confirm the diagnosis and start treatment. Some reversible causes can be easily treated using reversal or antidote agents, like dextrose 50 for hypoglycemia, thiamine for alcohol withdrawal, flumazenil for benzodiazepine overdose, and also naloxone for opiate overdose. This is the algorithm for the approach to coma. Pause the video and carefully read through. I hope it will help you during your on-call. If you found this session helpful, please give us a thumbs up and do not forget to subscribe to this channel. We will see you next week.